So this session is being recorded. It will be posted to the EIC website here under collaboratives and telehealth. We'll also post these slides to the website after the meeting as well. And this meeting is going to be held again next week for those who couldn't make it. So if you have anyone in your organizations that couldn't make it quite today, there is an identical call scheduled next week on Monday on the 31st at the same time for those who couldn't make it today. Next slide. So I just wanted to briefly go over acknowledgements. EIC is supported by the Health Resources and Service Administration of the U.S. Department of Health and Human Services as part of the Emergency Medical Services for Children Innovation and Improvement Center Cooperative Agreement, totaling a little over $3 million with 0% finance from non-governmental sources. The content presented here and throughout this webinar and the collaborative is that of the authors and does not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. So a brief agenda today before I turn it over to Kate to take away more of the description. We're going to give an overview of the collaborative. So that'll include kind of the background. Why are we doing this? Why are we launching this collaborative? The mission, goals, the timeline. We'll give an overview of the Telehealth Advisory Council that will be helping to support this collaborative, as well as take you through the application process, and then hopefully have plenty of time at the end for discussion and questions. So if you want to go ahead, Kate, you can take it away.
Thank you, Meredith. So good afternoon or good morning, I guess, for those of you in the Pacific Islands, but thanks so much for joining, and we're really excited to be able to talk to you all about this upcoming initiative. So what's important to realize is that prior to the most recent pandemic, I think many of you are aware that children accounted for about 20 to 25% of all emergency department visits. Yet since then, we've seen the greatest decrease in ED visits among those that are under 14 years of age. In fact, there's been over a 70% decrease in their overall visits since this time. And this effect has really had great potential to further marginalize children who are already considered to be a relative minority when it comes to emergency department visits. We also know that these other impacts, such as social distancing and school closures and socioeconomic setbacks and the like, have been associated with increased mental health issues, especially suicide, substance abuse, child maltreatment, and the like, which has really placed a very large population of children at heightened risk. And even more importantly, those children that have required or that require regular ongoing access to health services and or medications, because of these closures or decreases in clinic availability and the like, have suffered gaps in care and or potentially treatments, and that this has the potential to worsen and or lead to clinical deterioration. So all very important elements that we should all be aware of. So within this particular initiative, our effort is really to target two particular populations, which we highlighted more or less on the previous slide, which is children or youth with special healthcare needs. So those are defined as children who have increased risk for chronic physical, developmental, behavioral, or emotional conditions, and who also require health and related services of a type or amount beyond that required by children generally. Additionally, our focus will be on children with behavioral health emergencies, so children and youth with mental health, substance abuse, or other behavioral health issues requiring emergency care or other appropriate interventions. And what's important to note, and we'll speak about this as we move through the introductory presentation today, is that the expectation is not that every participant or participating team will be focused on both populations, but the overall goal of the collaborative as a whole is to make sure that we're addressing the needs of both of these populations. So specific to children with behavioral health emergencies, we know that over the last decade, there's been a growing epidemic of behavioral health issues among children in the United States, and unfortunately, a lack of available resources to support them. As we've just discussed, behavioral health is both mental health needs, substance abuse disorders, other behavioral health issues. And there was a recent study that demonstrated that over the last decade, pediatric ED visits, while they have remained stable, all mental health disorder visits have increased by 60%. Additionally, ED visits for deliberate self-harm have increased by 329%, and visits for substance use disorders have increased by nearly 160%. And what's especially important in relation to this is that among low volume and rural EDs, where generally speaking, children represent a significant minority, that there's been an increase by 12% among behavioral health visits. This is particularly important because, as you all know, low volume EDs often lack day-to-day infrastructure needed to stabilize critically ill and injured children, and that certainly includes those with behavioral health emergencies. Suicide rates over the last decade have disproportionately impacted children living in rural communities, where suicide rates in those areas are double those found in urban communities. And one of the greatest challenges facing rural communities in addressing these behavioral health needs is a shortage of behavioral health specialists that exist to support them. There are disparities in access to mental health care that differ significantly from region to region and across demographic areas. And this is all part of the impetus for this upcoming collaborative effort. When it comes to children and youth with special health care needs, we know that overall they account for about 15% of all US children, so more than 14 million children that have special health care needs. And over 20% of those children rely on emergency departments every year to help meet their needs. Approximately 3 million of those have what are considered to be complex medical conditions. And of children with medical complexity, about 2/3 of those are enrolled in Medicaid. And in fact, they account for about 34% of all Medicaid spending. Many of these children face physical and cognitive and emotional challenges on a day-to-day basis due to their underlying diseases, anger treatments, and their capabilities. And they often need a diverse set of services. That includes, of course, healthcare and education, mental health and social services. And because of this, families often face higher medical costs. Oftentimes they have inadequate health insurance coverage. And all of this can certainly lead to increased stress on these families. Viral illnesses pose an even greater potential risk for these patients who may be more prone to decompensate because of their underlying condition. And especially in the setting of public health emergencies, it can really pose an exponential threat to these children and their families. The public health crises that exist have the potential to cause postponement of necessary treatments due to exposure risk and/or access. They, as I mentioned, can lead to decompensation secondary to comorbidities. And then additionally, because of those risks, there may be avoidance or an inability to access the regular checkups that could otherwise prevent clinical deterioration. And so those postponement and treatments are significant. And this can certainly further stress coordination of care and can disproportionately impact this population. And so these really form the impetus for this collaborative that we are excited to be announcing, is that we know children and youth with special health care needs are at greater risk for various reasons, including comorbidities and risk of exposure, need for coordination of care, that postponement of care can lead to significant gaps. We know behavioral health emergencies, as I mentioned, are at epidemic proportions and are especially true in these rural settings, and that these public health crises such as COVID, influenza, and other viral illnesses have the potential to disproportionately impact these populations due to either limited access, limited resources that already exist, and or lack of continuity and or coordination of care. So telehealth has certainly been one strategy to try to intervene for patients and families across various populations, not necessarily specific to children. But the benefit of telehealth is it can bring expertise to otherwise low resource areas. Telehealth, of course, is one form of electronic health. It's a strategy that offers an alternate approach to meeting the needs of children. And the idea is that through this virtual technology, it can offer the same standard of care that would otherwise be provided for a given condition during an in-person visit, but it offers that care remotely. It can serve to prevent unnecessary or potentially avoidable transfers. It can help to offload patient care to less overwhelmed EDs. There can be opportunities to access care quickly without risking exposure to patients who would otherwise be at risk, or to those patients that would otherwise be required to travel to receive the necessary care they need. There are a number of potential benefits, not only just bringing pediatric or subspecialty expertise to low resource areas, but also in this current healthcare environment, there's really a demand for innovative technology. There's been, as many of you are aware, decreases in overall patient visits to the ED. That's forced many staff to be furloughed. And because of that, there's been a spike in the use of telehealth. Some recent developments have really helped to support this. This includes the CONNECT Act, which is a program that has helped to increase the ability of providers to utilize telehealth services. It's helped to increase reimbursement, allow for the use of different platforms such as Zoom and Skype for the use of telehealth connectivity. There's also been the of telehealth licensure compacts where multiple physicians can be licensed under various state level acts. And there's also been an increase in availability of funding to support telehealth efforts across the United States. There are still, though, however, a number of barriers that exist to the use of telehealth, and part of that is related to just competency among telehealth or general practitioners. Many healthcare providers may be unaware of how telehealth can be used. There may be barriers in licensing and credentialing, uncertainties regarding reimbursement and or billing practices, concerns regarding the infrastructure needed to support telehealth activities. And then, of course, some of these other efforts such as perceived costs, lack of knowledge around availability, and then true integration into electronic healthcare records, which is a critical step in order to ensure that continuity of care between visits and across healthcare providers. So because of all of this, we are excited to be able to announce an upcoming telehealth collaborative. We know that over the last 7 months, there's been significant increases in the use of telehealth, and really even over the last years, even before the most recent pandemic. And so we're excited to be able to work jointly through a collaborative effort to be able to launch this. Our hope is that beginning this coming month in September, that there'll be a request for applications that will go out for all of our EMSC state partnership teams, program managers, directors, whereby you'll have an opportunity to apply to be a participant in this collaborative. In December, we anticipate launching an environmental scan to better understand what resources exist currently within your jurisdiction, and to identify potential opportunities for telehealth work. And then from January to June will be the active collaborative, and we'll talk more specifically about the work that will be done during that collaborative over the coming few minutes. So the overall goal is to evaluate the impact of public health crises on these two particular populations, so children and youth with special healthcare needs, as well as those with behavioral health emergencies, to assess telehealth capacities, and to provide guidance and support to improve access to emergency care for these particular populations. And really with a special focus and or attention to rural, tribal, and territorial areas. And as I mentioned previously, the goal of participants in the collaborative is to focus really on one of these two populations, not both. We recognize that the needs and available resources for these populations are significantly different, and that the correct approach or the most viable approach may be significantly different. And we want to make sure that the participating teams have an ability to really focus on the needs of one of these two critical populations without being spread too thin by focusing on both. The goal of the participating state partnership teams would be to identify challenges that are facing these populations first and foremost, and particularly secondary to these public health crises. The second would be to complete an environmental scan to assess the infrastructure that's available to support that. And that infrastructure certainly includes elements of technology, but also includes the availability of healthcare providers to support the needs of these populations. Additionally, regulatory and or licensing requirements that may have been either lifted or might be in place to support the onboarding of new providers. And then, of course, reimbursement strategies that can help to support this effort. And then finally, the development of a strategic plan to begin to implement telehealth services within a target population. And the ultimate goal here is to increase emergency care access for children and youth with special health care needs, as well as those with behavioral health emergencies. The collaborative is really broken up into 3 phases. The first phase is really called the environmental scan, understanding what current gaps and or resources exist to support these activities and this effort. And as I mentioned, there's really 4 areas of focus here of understanding the landscape of healthcare providers and or the workforce to provide support to these populations, the regulatory licensing requirements, the technology and reimbursement. And it's anticipated that this environmental scan would really be the first step before we launch into actual learning and implementation and or strategic planning activities. And that this would take place over the month of December, if not during the whole application process, of really beginning to understand those capabilities. The second phase of this collaborative is really the planning phase, beginning to understand the key drivers that exist to either support or barriers that exist to potentially hinder the development of these telehealth programs. And really to begin to look at best practices that have existed perhaps in other venues, other populations around the country, to understand the needs and the gaps that exist for these populations, and to begin to think about, based on the resources that currently exist or the infrastructure that exists, how those can be utilized within your jurisdiction to support these populations. And then the third phase of the collaborative is really focused on implementation. How can we begin to really engage the pediatric healthcare workforce to support these populations? And that may be through training, it may be through true implementation efforts within networks or regions, and really making sure that we're continuing to engage the families and patients based on their needs and gaps. During the request for applications, I mentioned that that will be going out hopefully by mid-September. We'll aim to have that out sooner if possible. And the target for this is really our EMSC state partnership programs. So those of you who have already worked closely within your state to identify the resources that exist, the populations, the infrastructure that's in place to support this. And our goal is really to work closely with the EMSC state partnership programs through the development of their own internal teams to provide support. Our goal is to engage at least 5 and hopefully as many as 14 state and or territory teams in this work. Ideally, we'd like to have a minimum of 2 teams that are focused on each of the target populations. So our goal is to really create more or less an even split between those who plan to focus on children and youth with special healthcare needs versus children with behavioral health emergencies, because we recognize that the strategies, as I mentioned, may be somewhat different. What is really exciting is there is additional funding available to support those team activities. A minimum of $25,000 up to $50,000 per team based on the requested budget. And we'll talk a little bit more about ways that that funding can be used, but it can, of course, support personnel costs, it can support travel, it can also be used to support other infrastructure needs, materials, equipment, and the like. And specifically with respect to that funding, because we know that one perceived barrier to telehealth use in the past, especially prior to public health crises, was the need for high-end technology with high security. And what has occurred over these last few months since the COVID pandemic is that there's been increased leniency around technology use. And we want to make sure that all of the funding isn't going to developing a single piece of equipment or technology that requires significant upkeep or security elements to maintain, but really looking at the use of devices that can potentially be used to implement telehealth at a much lower cost. We know that EMSC state partnership program managers have a lot on their plate. And in previous collaboratives that we've launched through the EIC, we've recognized that there have been some really great best practices where EMSC state partnership programs have brought in alternate leads to really help drive these types of efforts. And what we will say is that the EMSC state partnership manager does not need to be the primary lead for the team. You can certainly identify an alternate team member, additional consultant or personnel to really take this on. But we certainly hope that the EMSC state partnership manager would remain very engaged in this work, part of the team, abreast of activities that are underway, because as a EMSC state partnership manager, you have the greatest level of understanding of the infrastructure that's in place to support these activities, the stakeholder groups that you've already engaged in EMSC activities and efforts. We do know that doing this alone is not possible. This is, a big ask to try to implement or develop a telehealth program that can really work to support these populations. And so we're asking that you really consider individuals that are needed to be part of your team. Certainly, because we're looking at these populations of children and youth with special healthcare needs, as well as behavioral health emergencies, we want to make sure that we're engaging those specialists as well as a general pediatrician with a greater understanding of the needs facing these particular populations. Engaging your state or territory health department would be enormously beneficial to better understand some of the regulatory and licensing issues that may serve as both barriers and or entry points to support these efforts. Because the work is really focused on emergency care, not general care, but how can we help support the emergency care needs, engaging either emergency medicine and or pediatric emergency medicine physicians. None of this work would be valuable without the voice of families, and so really having that family representative who can speak to the needs of these children, a telehealth provider who already has experience working with telehealth services, what networks might be available to support these activities, and then of course rural health representative for those areas where there's indeed a large population of rural health. This is really critical because one of our focuses, or one of our important pieces that we recognize, is the fact that, for example, suicidality, as I mentioned earlier, is twice as high in these rural communities. We also know that the resources are much less in these communities. And when it comes to public health crises and decreases in availability of services, we need to make sure that these specifically are the communities that we're reaching. We're also suggesting that you might consider some optional team members, such as family-to-family health information centers, and we'll talk a little bit more about that, child and or adolescent psychiatrists, child psychologists, hospital associations within your state or territory, a rural hospital association representative, tribal communities, social workers, child life, regional disaster coalition, and then other core stakeholder representatives who have been directly engaged in EMSC efforts. So I know I've already shared a lot of information, and I want to just pause for a minute and see if there are any questions that folks might want to add into the chat box before we move on. And we'll certainly have time for questions at the end, but if you have any questions now, as we go, we want to make sure we're addressing those. Great. So there are a couple questions, one about the timeline, and yes, we'll address that again in just a few minutes. Who's considered an emergency care network representative? So really what we're looking for is a representative. The definition of a network can be defined loosely or much more specifically, as you might think about a particular healthcare group that provides emergency care services. But it could be defined more loosely as a network of healthcare providers that would be providing the kinds of services that these patients might need. So it doesn't necessarily need to be a formal network, but at least a network of providers that have been engaged in supporting emergency care activities in this way, in this population. Hopefully that makes sense, Erica. So another question has been put into the chat box of, is this all focused specifically on hospital-based telehealth, or is it pre-hospital telehealth, or is it both? There have been some efforts underway to use things like Pulsera or video conferencing within the pre-hospital setting that can better support the needs of certain populations. That can include early triage of patients to alternate destinations. And so that certainly could be an area of focus within your jurisdiction. It could also be really with a specific focus on those children that intend to be in the emergency department setting or looking at alternative resources. The focus of this is really intended to be individualized based on what capabilities exist. We view this more as a learning collaborative where we're really trying to identify opportunities and best practices for which telehealth can be implemented to support these populations across the emergency care continuum. So that's a great question regarding the use of Pulsera. Can it be hospital, pre-hospital, or both? And the answer is both, or it could be focused on either. So I think that answers the other question regarding the use in paramedicine or mobile integrated healthcare providers, absolutely. And we'll be talking a little bit about measures as we go, but the goal is really to increase access to emergency care for these populations. And there's, a number of ways in which we might consider utilizing telehealth for these populations, whether it's for the purposes of screening or assessment, or actually providing care and or evaluation and treatment. But the ultimate goal is to increase the availability of healthcare providers that can support emergency care needs for these populations across the continuum. So hopefully that answers your question, Michael. Meredith, are there any other questions I missed in the chat box?
I don't think so.
Okay,
good.
Okay, great. And we'll keep going through questions as we go. So if other questions come up, please feel free to go ahead and put those in the chat.
Kate, this is Mark. Did you see the question about, I know you'll go out into outcomes in a moment. I just want to make sure you saw that Michael Kim asked that. That just came in.
Yeah, thanks. And that's what I was trying to address, is that the real outcome that we're trying to look for is the increased access. And the outcomes are a little bit variable depending on whether the focus is on children and youth with special health care needs versus whether the focus is on children with behavioral health care needs. But ultimately our goal is to make sure that we're increasing the availability of providers. And we'll talk a little bit more about some of these specific outcomes, but we do anticipate that we'll be going through some iterative cycles for what the specific metrics should be. And part of the reason for that is we're bringing in a really wonderful group of experts that will be helping to support this collaborative. This will be the EMSC Telehealth Advisory Council, and I'll speak a little bit more to that. So I'll maybe get into more specific details around those outcomes in just a few minutes. So the smart aim of this collaborative is that by June 30th, our hope is that 100% of participating states and territories will increase by 25% the number of pediatric healthcare providers who are ready and able to provide emergency telehealth services for the target population. So that's really what I was just speaking to. This is our smart aim. In prior pediatric emergency and the Pediatric Emergency Care Coordinator Learning Collaborative, we far exceeded the smart aim that we set out to achieve, thanks to all of the amazing work that the teams did, and to the leadership that came from the subject matter experts and Mark and Rachel and Kathleen and many of others who were engaged in that. But this is where we've started. We realize that this is a very short timeline with only 6 months available to really focus on this telehealth effort. And our hope is that by the end of that, based on the support that we know will be provided through the Advisory Council and through the opportunities for collaboration and sharing of best practices, that we'll be able to get there. We talked briefly about these 3 phases. So the first being the environmental scan to identify gaps, the second being the strategic planning, and then the third being the implementation phase. And that's really using that QI methodology of plan, do, study, act cycles. Within the environmental scan, really assessing the needs, assessing the impact of these public health crises, and identifying the resources. As we move into January, our goal will really begin to start thinking about strategic planning. What are some potential applications for telehealth based on the needs of the populations in our jurisdiction? How can we engage the workforce and or develop that workforce to engage in telehealth related efforts? And what are the infrastructure and regulatory requirements surrounding that? How can we address them? How can we support education related to them? And how can we bring on more healthcare providers to be able to support these populations? And then really the last few months of this collaborative will really focus on the implementation piece of beginning to really work and engage certain pediatric healthcare providers in supporting these populations. So there was a question about the timeline. So applications open mid-September and will close on October 31st. So it provides about 6 weeks. And The goal of these applications are not to be overwhelming. This is not to be, thought of as a massive grant application. And the application is not intended to be burdensome. What we do, though, need to know is what you plan to do, how you plan to target these populations, what resources exist to support you in that effort, and be able to walk through a generalized approach. We intend to notify teams of acceptance no later than November 30th. The goal would be to start that environmental scan in December and then launch the collaborative in January. We anticipate having bi-weekly learning sessions. The first learning session would really be focused on more of the didactics and the evidence and or strategies that have been already put into action. So there's been such a huge uptick in the use of telehealth across this country. And we're really looking forward to learning from the subject matter experts within the Telehealth Advisory Council and being able to share some guidance related to that during the first session of the month. The second session of the month was really be dedicated to the state partnership teams being able to report back on what they've learned, some potential approaches, and really that collaborative spirit of all teach, all learn, so that we can help to support each other and identify opportunities. So I'll pause again. I think there was another question in the chat box. So will the environmental scan be structured and or administered by EIC, New York, or the state? So the intent is for it to be relatively structured. Our goal will be over the first few months of working with the Telehealth Advisory Council, which will actually launch prior to the collaborative as we begin to work with the subject matter experts, will be to develop specific questions for that environmental scan. There's already been some really fantastic work underway through the Sprout Network, which is a pediatric telehealth network involving a number of healthcare providers across the United States. And they've already through that work have developed some baseline questions that would be critical to know and understand in terms of the infrastructure that's in place. We will be working with the Advisory Council to review some of those, identify some gaps that might be specific to the emergency care needs of children. While the Sprout metrics and questions that have been developed are really fantastic and provide a critical foundation, they were not specific to either these populations nor to emergency care in particular. And so the goal will be to really review those with the Advisory Council and be able to provide a more structured environmental scan that will help guide the state partnership teams as they identify opportunities and strategies. Thanks for that question. So the goal of the EMSC Telehealth Advisory Council is really to help identify some of those common challenges and needs. We've got all kinds of specialists from all over the country that will be joining this, and I'll tell you a little bit more about who they are in just a few minutes. Will also be to identify what requirements are really needed for the use of telehealth. There is quite a lot of guidance that's already available. We know about the variability in terms of regulations and licensing from state to state, and how that impacts the work that might be underway in your particular region. And then, most importantly, will be to begin to look at potential implementation strategies, as well as metrics to Dr. Michael Kim's question of what specific metrics and outcomes will you be looking at. We have our SMART aim identified. But this, as I mentioned, may be an iterative process and one by which we continue to evolve. But the goal is really to bridge those gaps in emergency care for the target populations. These are the 9 topic areas or focus areas, and you might have seen those outlined in the timeline. So during the first couple months, we'll really be looking at the challenges and needs. We'll be looking at the impact of public health crises, and we'll be looking at potential resources that are available. During And much of that really stems from the environmental scan, which again will help to provide support for that. The second couple months will really be starting to develop a strategic plan. What are the strategies that will most work in my community? Will it be focused more on the hospital or more on the pre-hospital setting? Will telehealth be used predominantly, or is the greatest need for assessment? Is it for stabilization? Is it for continuity? Is it simply for access or identifying alternate destinations? How might telehealth best be used in our populations? Who is the workforce that we might be able to engage? What's the infrastructure that we need to work within? And what are the metrics that we really should be looking at? And then finally, those last few months really focused on implementation strategies. We're excited to welcome some really wonderful individuals to the Telehealth Advisory Council. Many of you may know a number of these people that we're grateful for their time and energy and expertise. So Dr. Ryan Brown, he's an official member of the Choctaw Nation. He brings a wealth of expertise related to Indian Health Services and tribal emergency departments, and worked very closely with HRSA EMSC and the American Academy of Pediatrics to look at pediatric readiness within emergency departments and tribal communities. And he has a real depth of understanding related to the challenges facing our tribal communities. Doctors Tom Chun and Sue Duffy both bring expertise into the behavioral health arena. Dr. Chun is triple boarded in both pediatrics as well as in psychiatry. He has written the national guidelines on behavioral health emergencies, which was a joint policy statement released just a few years ago. And Sue Duffy has been really instrumental in implementing telehealth activities within her emergency department to focus on the behavioral health needs of children. Dr. Marie Lazan is a professor of emergency medicine with a great focus and work in reaching out to emergency departments across the region. She has been doing a ton of work related to disaster preparedness and has really been the telehealth lead in disaster planning through the work of the Pediatric Disaster Care Centers of Excellence, and we're super excited to welcome her. All of you know Laura Ludwig very well and are very aware of the enormous effort she put forth to develop the Critical Crossroads Toolkit. She brings so much expertise relative to the rural health community and the needs of children with behavioral health emergencies, as well as the importance of cultural humility and competencies related to that. Michelle Macy is from Northwestern University. She is a member of the Sprout Working Group, developing telehealth specific metrics. She's a health services researcher and really brings a wealth of expertise to that. Marie Meehan is within the Health Resources and Services Administration, well known for her work with children with special healthcare needs and a wonderful contributor to the NPRP toolkit. Jim Marson, many of you know, who's the director for the Center for Health and Technology at UC Davis, and has been working in the world of telehealth for the last several years as one of the Sprout grantees in the Northern California region. Sarah Ronis is the director of the Child and Health Policy Institute at University Hospitals. She also is a general pediatrician by training with a focus on children and youth with special healthcare needs and understands the gaps facing these individuals. And then we have a number of organizational partners that you see listed here that we're excited to welcome that will be providing guidance and support to our participating teams over the course of the collaborative. So how to apply, again, applications will be available mid-September, due October 31st. Notification of selections will be made no later than November 30th with the plan to launch the collaborative in January. It'll likely be mid-January to allow time for folks to recoup after the holidays that we know can be challenging to get back into the fold. We have developed a telehealth collaborative website, as Meredith mentioned earlier. So if you go to the EIC website and look under Quality Improvement Collaboratives, you'll see a link to telehealth. And there's a whole page of information, background, summary, timeline, etc. And that is where the application will be posted as soon as it's fully available. We intend for the application to be completed through REDCap. So this is not through EHB. It's really just through REDCap. There'll be opportunities to upload documents. So if you have, a couple paragraphs that you want to share relative to certain areas, that you can upload those. The goal here is not to create an 80-page application. The goal here is to make this really accessible so that we can meet the needs of the populations in your regions. The types of information that we will be requesting as part of the application are listed here. So what we really will want to know is a little bit more about the demographics and population served, especially including rural, tribal, and/or territorial communities. So where are these children within your state and across your state? Where are those needs? Whether your intent is to focus predominantly on children and youth with special healthcare needs or those with behavioral health, really the goal is to choose one or the other. The intent is really not to focus on both, because we recognize that, again, the strategies are really highly variable. But if you have a clear reason why it's important to focus on both, certainly that's acceptable, but the goal is really one or the other, so that we can really be successful in achieving our aim. The next is really the team composition, and I went through some of those members. So certainly doing this alone is not possible. It takes an army, and we've made some suggestions regarding individuals that we think would be helpful to your team. But if there are others, you're certainly welcome to include a larger team as you see fit. We'd also like to know if there's any current efforts that are already underway at the regional, state, or territory level relative to the use of telehealth and/or to the focus on the needs of these particular populations. What specifically are the needs within your communities? Who are these children in terms of where they live and where the gaps might exist based on changes since these public health crises have come into play, but also just at baseline. What are the regulatory terms that exist within your state to help support the use of telehealth? What is the budget that or how do you plan to spend the additional funding? A letter of intent, of course. And we would like to know a little bit more about the presence of a pediatric readiness medical recognition program, whether there's already one in place or is underway, as this is a potential opportunity to further support that effort. This is just a breakdown of how applications will be scored. So you can see that, and this will again be on the website. The application will be reviewed by a number of individuals, EIC representatives, FERSA representatives, other federal partners, and some members of the Telehealth Advisory Council. The goal is to make sure that there is truly a wide distribution of teams and participants. As I mentioned before, our hope is to take as many as 14 state partnership teams. We absolutely want to take at least 5. And really much of this depends on, the need, the budget, and, of course, the interest. So we really do hope that all of you will consider applying, and, as you have questions related to this, we're happy to answer those. These are again the list of suggested team members. I'll leave this up here for a few minutes so you all can look through this. And I think there were a number of other questions that popped into the chat box. So there are concerns regarding the availability of EMS clinicians and or EMS directors and the Telehealth Advisory Council. And I absolutely agree with you, Sam, thanks for sharing that. I think our suspicion was that the great majority of teams would be focused more on hospital-based care, but if we see from those of you in the chat box as well as others that there's a real interest in EMS. There's certainly a number of efforts that are underway in the pre-hospital world. The Ethan Project is one of those out of Houston Fire Department, and there are certainly plenty of others. There are many states that are launching Pulsera and other video opportunities within the pre-hospital setting. And thanks for bringing that to our attention, and we can certainly invite some EMS specific providers who've been engaged in that. Part of the challenge with pre-hospital expertise and the reason why we didn't bring them in immediately up front as well is that we know that many of these EMS agencies have been overwhelmed by COVID during this time, and that their availability to support this effort may be challenged. But no doubt we can identify some additional experts, and if you have specific recommendations, we would be very much open to hearing who those individuals might be so that we can bring them into the fold. Another question, the family voice would be of great value. Absolutely. So we have reached out to the Family Advisory Network to seek representatives. And what you may not have seen is that we've also reached out to a national organization called Family Voices, which has established family-to-family health information centers in nearly every state and territory, including in tribal areas. And these are health information centers that are run by families to support families who have children and youth with special health care needs. And so absolutely, we recognize how critical the family voice is. And we're excited to be able to have at least one, if not two, fan representatives on the Telehealth Advisory Council, as well as representatives from Family Voices. And then, you know, our recommendation is to have a family representative on each state partnership team as well. There was another question related to the slides being available. Absolutely, these will be available on the telehealth webpage within the EMSC Innovation and Improvement Center website. So you'll absolutely be able to reference those. And as we mentioned, this was a recorded presentation. So if need be, if you need to share this with others, you're welcome to do so. You will have access to that. Can we clarify the requirement for the Pediatric Readiness Medical Recognition Program? Is this required to be considered? No. This is not required to be considered. Really, the question is whether there are any efforts underway or have been underway to create any kind of Pediatric Readiness Medical Recognition Program. The overall amount of points related to this particular piece is 5 out of 100. It is not essential to be required or essential to be, you know, a participant in this collaborative, but we do recognize the benefit of being able to link those. And I would say that if your focus, if you choose for your focus to be predominantly on the EMS realm, then it would be worth mentioning, and we can certainly adopt the application for this, whether there's an EMS medical record or an EMS recognition program in place, because that too would be important. There's a question, does direct medical oversight of EMS providers via telemedicine fit under the umbrella of the collaborative? You know, that's a great question. Mark, thanks for asking that. I think one piece of this is just to be able to make an argument as such. Much of the online or direct medical oversight through EMS is not specific to children and youth with special healthcare needs, nor children with behavioral health emergencies. And that's really the focus of this particular collaborative effort. So I think if it's just standard online medical direction, it really wouldn't fit the needs. But if there is a way to further expand that effort to make sure that there's online medical direction and oversight specifically available for these populations, then it could be deemed, valuable. Thanks, Sam, for your comment. What I did fail to mention is that we do work closely with NISIMSO, AAP, ASAP, ENA, and American College of Surgeons, and we've invited representatives to serve on the Telehealth Advisory Council, but we can make sure that they're specifically EMS medical direction. Robin, thanks for your comment. EMS oftentimes transport patients with behavioral health issues. Absolutely, and we know there's been a significant increase in the number of children seeking 911 services for behavioral health, and that is a growing need. So absolutely important to address. And I think I've hit all of the comments. If there are others that come up, please share those. I know we're at the top of the hour. We're really grateful for you all joining, and there will be more to come. Again, this will be, this was a recorded session. It will be available on the EIC website. You're welcome to reach out directly to us if you have additional questions. And we'll be holding a second session on August 31st. It will be more or less the same information. You're welcome to come back and join, especially if other questions come up. And we'll try to make sure we have lots of time to address those. So thank you all so much for your time today.
Kate, this is Mark. I just wanted to make a quick plug for if you, are interested. Certainly, Kate and EIC as a whole is one pathway to ask questions. But another thing that I would just encourage state partnership grantees to consider is reaching out to Rachel, myself, or your state representatives through EIC, and we're happy to provide some coaching and experience, to you that might be customized based on your relationship with us and such. So please feel free to reach out to Big EIC, to the EIC group focusing on this, but specifically Rachel and I are here to help provide some, office hours type of approach if needed. If people have more specific questions, we'll make sure to get them answered for you.
Thanks for that, Mark. Okay, thank you all so much for joining today. Take care, stay safe.